Hi, this is Mason Garfield. I'm a PA student at LSU Shreveport, and today I'll be talking about sepsis and systemic inflammatory response syndrome. We are going to start with general features for sepsis and SIRS. To understand sepsis, you first have to kind of look at SIRS criteria, which is a clinical syndrome comprised primarily of vital signs, so temperature, heart rate, respiratory rate, but it also includes white blood cell count. Sepsis is diagnosed by having two or more positive SIRS criteria with suspected or identified infectious source. How sepsis works is it's basically an inappropriate systemic response to infection, and the most common cause is bacteremia. So the infection can be fungal or viral or, even parasitic. However, the most commonly seen one is bacterial infections that cause some sort of systemic response. So urinary tract infections and pneumonia are some of the most common causes, but there are many. As far as clinical assessment goes, the signs and symptoms and physical exam findings of sepsis are highly dependent on the original source of infection. So you plan to see positive SIRS criteria in any septic patient. So whether it's tachycardia or a fever, the other signs and symptoms are largely dependent on the actual original source of infection. So if they have pneumonia, they may present with some sort of productive cough. If they have a UTI, they may present with dysuria. If they have some sort of cellulitis or soft tissue infection, you will probably have skin findings. So the main purpose of physical exam is to kind of identify the most likely culprit or original source, as well as determine the hemodynamic stability and potential prognosis of the patient. Now that we've covered some of the general features and kind of how sepsis presents, SIRS criteria is pretty basic yet detailed. It includes temperature, heart rate, respiratory rate, and white blood cell count. So you can see these findings here. If they're febrile or hypothermic, so less than 96.8 Fahrenheit or 36 Celsius, that is a positive SIRS criteria. Heart rate greater than 90 beats per minute is another positive SIRS criteria. Respiratory rate of greater than 20 breaths per minute or tachypnea or hyperventilation with a PaCO2 of less than 32 on ABG, which if you recall the normal CO2 on ABG is 35 to 45. That's another positive SIRS criteria. If they have a leukocytosis greater than 12,000 or leukopenia less than 4,000, that is another positive SIRS criteria. There is a caveat that includes greater than 10% immature white blood cell forms, also known as bands. There could be an entire separate presentation on these band forms, so we will just leave it at that for now. Sepsis is diagnosed as having two or more positive SIRS criteria with an identified or suspected source of infection, and then it's further classified into severe sepsis, which is the presence of sepsis with lactic acidosis or hypotension. Lactic acidosis is signified by a lactate of greater than 4 millimoles per liter in an acidotic patient, so a pH of less than 7.35 on ABG. And then septic shock actually can't be diagnosed until after fluid resuscitation has been completed because this is severe sepsis that is refractory to fluid resuscitation. So to kind of continue on after talking about SIRS criteria, obviously you're going to want to get a CBC because white blood cell count is one of the four major contributing factors in order to make a diagnosis of positive SIRS criteria or sepsis. Other labs you're going to want to get include CMP to evaluate renal function, electrolyte abnormalities. A urinalysis may be useful for identifying a potential source of infection in the urine. And then blood cultures, you're going to want to draw these before you initiate antibiotics from two different sites. You do it before antibiotics to try and prevent false negatives, and you want to do it from two different sites to try and prevent false positives from contaminants. Source cultures are kind of plus or minus based on what the suspected source is. If you have chest x-ray findings that show pneumonia, you don't necessarily need to go ahead and get a sputum culture or do a bronchoalveolar lavage or anything like that. However, If you have a urine infection, well, a urinalysis will usually reflex to a urine culture, and this can kind of help guide antibiotic targeting down the road. Lumbar punctures are usually only indicated if there's some sort of acute onset AMS or other signs of a CNS infection. And then you're going to want to check your baseline acute phase reactants to see kind of how widespread the infectious response is, so ESR, CRP. And then lactate's going to tell you kind of how much tissue hypoperfusion is ongoing. And so if they are found to be in lactic acidosis, you're going to want to follow up lactate after initial fluid resuscitation to kind of see if that has restored tissue perfusion and sort of alleviated the ongoing issue with oxygenation. And also, an ABG is mainly going to be indicated if you have some sort of altered mental status or existing elevated lactate, something that kind of points you in the direction of an ongoing metabolic acid-base disturbance. Imaging is going to depend almost entirely on what your suspected source is. So if you have a productive cough, you're going to want to get a chest x-ray. If you have hematuria or some sort of flank pain, you're going to want to get a CT abdomen pelvis to further evaluate the kidneys, so on and so forth. Once the diagnosis of sepsis is made, you want to start, after blood cultures, you want to start fluids and empiric antibiotic coverage pretty soon, because delays in antibiotic initiation is actually linked to increased mortality in sepsis patients, according to a variety of studies. So with the fluid resuscitation, the goal of this is to kind of maintain adequate intravascular volume in order to ensure appropriate organ perfusion. But you have to be careful in patients that have CHF or hepatorenal disease because they are prone to some sort of fluid overload, and this can easily deteriorate into cardiogenic shock. Now, as far as antibiotics go, you want to start broad and kind of narrow your selection as appropriate. So if you end up getting culture results back and it shows a specific resistance and specificity report, then you need to tailor your antibiotic choices in order to treat the microbe effectively. So most empiric therapies are going to cover MRSA and Pseudomonas, especially if the patient is in the hospital, because they have a lot of shared risk factors such as long-term care facilities, recent hospitalizations, recent antibiotics, etc. And so popular options for covering MRSA are vancomycin, linezolid, and daptomycin, whereas Pseudomonal coverage is kind of broad, but the main ones that I've seen have been piperacillin tazobactam, or Zosyn, cefepime, and meropenem. So after you kind of start antibiotics, start your fluid resuscitation, and you have your cultures pending, you want to just monitor for basically your response to therapy. So you do this by kind of trending signs of end organ damage. So this includes CMPs or renal function panels for progression of an AKI. You want to observe the patient and make sure that there's no acute onset altered mental status or stroke-like symptoms that could signify decreased brain perfusion, or ARDS and respiratory distress in a patient who is having to work harder to try and maintain organ perfusion. So trending lactate is important to try, and ABGs, in order to try and kind of get a picture of where the patient is on an acid-base disequilibrium scale, as well as their vitals. Their vitals will tell you a lot about their response, especially to the fluids. So this typically will resolve tachycardia. It may kind of improve their overall oxygenation status, but you want to keep a close eye on these things as they will tell you how effective your treatment is. And then you want to consult the appropriate specialist. If your patient has a worsening AKI and they become anuric, you may want to have nephrology there to facilitate dialysis. And critical care is also a specialty that's often consulted for these patients that are really sick because they may need vasopressors or need to be intubated and on mechanical ventilation. So overall, it's all about getting all of your specialists kind of on board early in order to prevent deterioration in these patients because sepsis can go south quickly. And so we're just going to finish up by kind of going over my sources, and that's all. Thank you. some of my references. This concludes my presentation.